This part of the presentation is going to focus on seizures. So what exactly is a seizure? A seizure is a sudden, uncontrolled electrical disturbance in the brain, which can cause changes in behavior, movements, feeling, and alterations in level of consciousness. Seizures are the most common neurologic condition in children. They are caused by excessive and disorderly neuronal discharges in the brain, determined by the site of origin, or they can be a symptom of an underlying disease process. So there are many other causes of seizures that are not listed here, but this gives the general sense that there are many things that can cause seizures. There are about 100 genes found to cause epilepsy syndromes in children. So some causes of seizures include fever, infections, CNS lesions, traumatic brain injury, metabolic disorders such as hyponatremia or hypoglycemia, tumors, genetic component, or there may be an unknown etiology. We may see seizures classified not only by their type, but by their etiology. So you may see them classified as acute symptomatic, which would be ones from head trauma or meningitis. Those that are remote symptomatic, so a patient or person having a prior brain injury, such as encephalitis or a stroke. You may see them classified as cryptogenic, and then idiopathic. So seizures were classified and sometimes still are according to their type and etiology. And then the International League Against Epilepsy in 2017, their classification of seizures focused on the location of onset rather than the etiology. Any witness or report from the patient is helpful in distinguishing what type of seizure that the patient has. You'll see focal or your partial seizures. These have a local onset and involve a small location of the brain. They can arise from any area of the cerebral cortex. Your frontal, temporal, and lobes are the most affected. The EEG will have or show unilateral spikes or sharp waves. Then you have your generalized seizures, which affect both hemispheres of the brain and are without local onset. And then those that are unclassified or unknown are seizures that cannot be categorized as partial or generalized. And these may be classified further as motor or non-motor in type. Focal seizures are further classified according to the level of awareness. This is important for safety and everyday life. Additionally, the first symptom of the seizure is the most useful feature for identifying the region of the brain that the seizure comes from. They're also classified by the initial onset, like I said, the initial onset feature. So you may see focal seizures without impaired awareness. And so you'll have sensory symptoms that occur in one part of the brain, causing no alteration of consciousness. The seizure described as focal clonic seizure with impaired awareness, or these are sometimes accompanied by motor movements. Then you may have some seizures described as focal to bilateral tonic-clonic. It's a lot to say, seizures. And these are focal seizures with or without awareness that evolve into generalized seizures, usually a tonic-clonic event. Then there are your generalized seizures, and the initial involvement is both hemispheres of the brain, and they're classified as generalized, and then they're classified into motor onset or non-motor onset. Then a loss of consciousness and motor function occur typically at the onset of these types of seizures. You may see the ones that are classified with motor onset. You're going to see maybe they will be tonic-clonic. You might see them classified as atonic seizures, myoclonic seizures, tonic seizures, and then clonic seizures. So tonic is the stiffening, and the clonic is the rhythmic movements. They're sudden onset with brief loss of awareness. You may end up seeing that they're going to actually have a blank stare as well. Then you have the atonic, which this is a sudden, momentary, and total loss of muscle tone. You'll see severe head drops or falls to the ground and loss of consciousness. Then you have your myoclonic, which are shock-like movements of a muscle group. The face or trunk or one or more extremity is often affected, and these may or may not be symmetric in nature. And then your tonic movements, this is the sudden onset of increased tone. And then your clonic is the loss of consciousness and decreased tone with jerking movements. And then you also have seizures that there is no motor onset, or it's a non-motor onset, and you'll typically see these called absence seizures. Although we now focus on classifying by location of onset, it's important to understand if these are recurrent or non-recurrent seizures. There are many different causes of seizures in children. And so with recurrent, these are chronic. They occur more than once. And then those non-recurrent, these are acute and they happen once. So typically the recurrent ones are then often classified as a person having epilepsy. And these can be caused by trauma, prematurity, congenital defects, hemorrhage, infections, toxins, degenerative defects, or they can be idiopathic. And then your non-recurrent or your acute, these may be caused by a hypoglycemic event or hyponatremia or hypocalcemia, maybe a head trauma, febrile episodes, and anoxia. So now one type of seizure I wanted to focus on because they're specific to infants and children are febrile seizures. This is a seizure in association with a febrile illness in the absence of a central nervous system infection or acute electrolyte imbalance in children. These often occur within 24 hours of the onset of a fever and can be the first sign that a child is ill. So a febrile seizure is a convulsion in a child caused by the spike in body temperature, often from some type of infection. They occur in young children with normal development without a history of neurologic symptoms. So it's important to note it's not how high the fever goes, but just that general spike of the temperature. So usually a child having a febrile seizure shakes all over and they lose consciousness. Sometimes the child may get very stiff or twitch in just one area of the body. The fever that's triggering this febrile seizure are normally caused by a viral process and less commonly by a bacterial infection. Influenza and viruses that cause roseola are often accompanied by high fevers, and these appear to most frequently be associated with febrile seizures. But again, having a febrile seizure, it's not a matter of how high the fever goes because it's continuing to increase. Having a fever of 104 doesn't automatically mean that the child's gonna have a febrile seizure. It's having that spike in that temperature that triggers the seizure activity. And these often occur in younger children, and often you're going to see them occurring between children ages 6 months to 60 months or 5 years old. With the greatest risk factor being between children or infants ages 12 months and 18 months of age. Some children inherit a family's tendency to have seizures with a fever. And additionally, researchers have linked several genes to a susceptibility to febrile seizures. With our assessment, again, we want to obtain that history to figure out, was there an onset of illness? Do that analysis of symptoms. Were they febrile? We want to check to see, always with children, are their immunizations up to date? Do they have any significant medical history? Because again, remember, we're just trying to obtain some clues as to what is going on. And then we need to do our physical exam. And then know that when we're evaluating febrile seizures, they really may be diagnosed based on history and exam. But some diagnostics may be obtained because, again, we need to rule out, are there other underlying causes for the seizure beyond them having that fever? So you may see a CBC performed, looking for imbalances, cultures for the cerebral spinal fluid. Do they need to do a toxicology screen, CT or MRI, evaluating for a head injury, and may obtain an EEG. So treatment, most of these really do stop on their own within a few minutes. And the most common complication of a febrile seizure is to have more febrile seizures. So most of these febrile seizures do stop on their own within a few minutes. But can be very scary for families, and they will call for help, and by the time help arrives, normally the seizure does stop. But there can be ones that are recurrent febrile seizures that these last longer than 5 minutes. And acute treatment for these would be rectal diazepam or buccal lorazepam or maybe intranasal midazolam, depending, because they most likely will not have a IV access, especially if they're at home. And then seizures lasting more than 10 minutes after acute treatment can treat for febrile status epilepticus and often will need to give IV anti-epileptics. Another thing to note with febrile seizures, antipyretics such as Tylenol offer symptomatic relief for the fever associated with symptoms, but this does not prevent the seizures from occurring. So treatment. So most febrile seizures do stop on their own within a couple of minutes. If a child does have a febrile seizure, it is important to teach the parents to stay calm, and we need to teach them what do they need to do. Place them on their side so they can't fall. We need to keep them safe. We don't want them to become injured. We want to time the seizure. We want to know what's happening. We want to comfort our child, make sure we're removing any things that can injure them during them having the seizure. Make sure if we can, loosen restrictive clothing. We want to make sure that we're not restraining the child or interfering with their movements. We want to make sure we're teaching not to place anything in their mouth. And if the child does have a febrile seizure that lasts longer than 5 minutes, or if they're having repeated seizures, they need to call for emergency medical attention, so calling 911. And again, teaching them that antipyretics will help fever symptoms, but not prevent the seizure. And now we're going to talk a little bit about epilepsy. So sometimes seizures are a one-time event, and then other times they are recurring and the child is diagnosed with epilepsy. So this is when an infant or child is having at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and a probability of having further seizures after 2 unprovoked seizures occurring over the next 10 years. So really having more than 1 seizure. Seizures may be a symptom of an underlying disease process. These can be caused by a variety of pathologic processes in the brain. Optimal treatment and prognosis requires an accurate diagnosis and the ability to be able to determine a cause. So now, etiology of epilepsy, again, infections, genetic mutations, brain injury or a tumor, abnormal blood vessels or bleeding in the brain. But the most common is idiopathic, or there's no underlying cause. We just don't know. The diagnosis of having a seizure or having epilepsy is a process. So the assessment and diagnosis rely heavily on a thorough history, skilled observation, and several diagnostics. So we want to know, what does their seizures look like? Sometimes we may not know that they're seizing. They have subtle movements such as eye deviations or their arms are raised. So it's really important to obtain that detailed description from someone who witnessed the event. What were the events that precipitated the seizure or that happened right before the seizure occurred? What was the duration of the seizure or the movements that were going on? Is there a family history? Again, doing some labs, maybe looking for infections, blood glucose, looking for hypoglycemia, electrolytes, looking for metabolic disturbances, and a chromosome analysis looking for genetic components, lumbar punctures, evaluating for meningitis, CTs looking for cerebral hemorrhaging, infarcts, tumors. So a whole bunch of things that could be done. And then the EEG, which is to see the brain waves or electrical activity of the brain. So an EEG is obtained for all children with seizures. They often are the most useful, and it can confirm the presence of abnormal electrical discharges and provides information on the seizure type and focus. But they typically, if they're going to be doing an EEG, it really should be done 24 to 48 hours to be able to see that they were having seizures. It really is important to know while they're getting the EEG, it may not show abnormal activity. But if there is a concern about whether a child has a seizure or the seizure type can't be determined, then you may see patients getting a long-term video EEG, and this may be done to record the child during wakefulness and sleep. So it's longer, like a video EEG, 24 to 48 hours. So really documenting maybe what is going on with that child to get a better understanding. So now when a child is having a seizure or seizure-like activity, what do we need to observe for? We're going to describe the onset of events, noting their behavior, changes in facial expressions. Are they crying? Is there any movement, activity? What's the position of their eyes, their head, body, extremities? Is this occurring unilaterally or bilaterally? Is there any posturing? And at the time of onset, were there any precipitating factors? Did they just take a medication? Was there an illness? Stressors? Are they sleep deprived? Watching for, again, if there's any tonic or clonic activities. Looking at their face. Are there any color changes? What's their mouth position? Is there any foaming? Are they biting their tongue? What's their expressions? Looking for their eyes. Are they twitching? Are they deviating to the left? What are their pupils looking? Are there any changes in size? Other things that we look for is their respiratory effort. Are they having periods of apnea? If they're in the hospital and on monitors, are they having desaturations? Do we need to suction them? Do we need to administer oxygen? You may notice that they have incontinence. And then we want to look at that post-ictal period. So again, their level of consciousness. Are they sleepy, disoriented? Do they have any changes in their motor function? So now I want you to practice. So looking at this child, just think about what would you chart for this child? When do you think the seizure starts for this patient?
यार हाय हाय ये ना हाय 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 चलो
So for that video, it can be hard because there was some lip smacking going on throughout. And it looks like it may have occurred or started at 17 seconds and ended around 26 seconds. And the movements are what I would note, or what you'd want to be recording, is looking at that eye movement, where then eyes started to deviate downward and to the left, and movements stopped. Okay, so it was like stiffening and eyes deviating downward and to the left were the main things that had noted. And then once the seizure had ended, you continue to see like the lip smacking, moving of the different extremities, and eyes not just deviating to one side, they were moving around in different areas. And so now another example of a seizure that I'm going to play is an absence seizure, or this is a brief loss of consciousness, and this causes lapses in awareness. Sometimes you'll see staring, and these have a generalized onset seizure, so meaning they begin in both sides of the brain at the same time. They typically can begin abruptly and then end. Sometimes they last only a few seconds. Absence seizures can be so brief that they sometimes are actually mistaken for daydreaming, and they actually may not be detected for months. They are more common in younger children, but it's really children from ages 4 to 14. However, older teens and adults may have absence seizures as well. But our first clue that a child may be having absence seizures is when they start having trouble in school. So then they get further evaluated. So I'm going to go ahead and play that so you can see what an absence seizure looks like.
Doing a long video, honey. You can see you. Bless you, William. Haley, what's up? Haley, what's up? Haley, what are you doing?
Oh, thank you, William. That's for sharing. Seizures right. You got it? Yeah, they're sharing.
It was 3 minutes.
3 minutes?
I need pops.
Check out those pops. Haley. 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 Hi. Can you hear me? Oh, Joey, hi. Voice, please. You scratch.
Oh, one of these. It's awesome.
You like drawing pictures, maybe? What's your favorite thing to draw?
Parties.
You like to draw parties?
Yeah.
Like people at parties, or just
People at parties. I got my dog. Wow!
Haley? Haley, what are you doing? All those waves, William, are making water go out of the pool, though, honey. Haley?
So that you can see would be maybe a little bit harder to detect if you didn't know or know the child as well. So again, you can see why that may take a little bit longer to diagnose. So now when a patient is having a seizure, what are some of the things that we need to do during? So again, note the time. We want to make sure we're providing a safe environment and really protecting them from injury. So seizure manifestations will vary, but we want to protect them, like I said, from injury. We don't want to restrain them or put anything in their mouth. We can suction, but we want, if they have increased secretions or foaming at the mouth, but we want to make sure that they're not hitting their head or causing further injury to themselves. We want to maintain a patent airway. So again, with suctioning or placing them on oxygen if they need. And for airway, again, it's important. If they are hospitalized and they do have a history of having seizures, we want to make sure that emergency equipment is at the bedside, because we never know when someone is going to seize, especially if they have a history. And even for your patients that don't have a history of seizures, always check your emergency equipment, because if you're checking it 100% of the time, anytime you need it, it will be there 100% of the time. And then if the patient's having a seizure that's lasting longer than 5 minutes, you often will give some medications. So these medications to stop that seizure quickly would be rectal diastat, lorazepam. Other meds that you may see followed would be phosphenytoin or phenobarbital. So patients with a history of seizures will have a rescue medication plan in place. So therapeutic management, there are multiple types of therapeutic management for seizures, and these include medication therapy, ketogenic diet, vagus nerve stimulation, and then epilepsy surgery. So I'm going to go ahead and talk about this in a little bit more detail. So the primary therapy for seizure disorders is anti-epileptic medications. The goal is to control a seizure or reduce their frequency. So we want to be able to discover and correct the cause if possible, and then help them live as normal of a life as possible. So treatment with these medications usually starts with a single medication known to be effective for that type of seizure and to have the lowest toxicity, so the safest side effect profile for the child's particular type of seizure. So really the goal is monotherapy. So these medications are started at low doses and then increased slowly in order to achieve desired effects, or steady state to control seizures is what we want. And then we need to monitor drug levels. Complete control by medications is achieved in approximately 70 to 80% of cases. And again, like I said, monotherapy really is the goal. So we begin these medications at a low dose and then increase slowly to really be able to control that seizure. If there is no control, then we will switch to another medication. There are then a lot of patients that will need or require combined therapy if it's not controlled by a single medication. So again, like I said, the goal is really to do monotherapy, but if that's not effective, we are going to then slowly increase that one medication to see if therapeutic results can occur. And if they don't, if they're not controlling the seizure, then they would move on and add another medication. Another treatment that you may see is a ketogenic diet. So this is a high-fat, low-carb, adequate protein type diet. It forces the body to use fats as the primary energy stores instead of glucose. So this diet is deficient in vitamins, so they will need a vitamin supplement. And this ketogenic diet, it's found to help control seizures, and the control is sometimes comparable to anti-epileptic medications. So this is based on the finding that starvation, which burns fat for energy, has an anti-epileptic effect, but the mechanism of action is really still not well understood. But many may still try this in order to help reduce seizure activity. Then you have your vagus nerve stimulators. So this can be used when medications are not controlling the seizures well. And what this does is delivers impulses to the left vagus nerve. So vagus nerve stimulation therapy is a treatment for epilepsy that involves a stimulator or a pulse generator, which is connected inside of the body to the left vagus nerve in the neck. The stimulator then sends regular, mild electrical stimulations through this nerve to help calm down the irregular electrical brain activity that leads to seizures. And this may be used for patients with partial onset seizures. Then the last therapy is surgical therapy. So this is reserved for incapacitating refractory seizures. So seizures caused by hematomas, tumors, or cerebral lesions do require surgical removal to really help with that seizure activity. So parental information, what do they need? If they're on medications, how to give these medications. And if they do, they're going to have those rescue medications, that diastat at home, how to administer that. I'm looking for some of these medication side effects, when to call for help, how to manage that seizure at home, so how to keep them safe. We can help talk to them about how to tell their siblings, families, and friends, and to raise awareness. And if a seizure does occur when they are with other people, how to identify it, and then who can they call for help, or when to call for help. And then talking with the school, making sure that the school knows that this child has a history of seizures, that they have rescue medications at the school, and then talking that to them about different activities or activities that they may need to use more caution with and be involved with. Okay, so if there's a school nurse, discuss with the school nurse that the child has seizures, discuss with the teachers, and if we can, try to normalize that the child has seizures. So we really want to, again, inform those that will be around this child, so if it does occur when they're around them, that they know how to help. And there are some schools that have seizure smart school education initiatives, and these educational programs are designed to actually help provide students and staff with proper information related to seizure recognition, first aid, as well as to help alleviate the stigma and misconceptions surrounding epilepsy in the school environment. And then what is the effect on growth and development? Or what are some special concerns, especially for adolescents? Again, normalization is important, and we need to understand, obviously with all children, but especially with adolescents, What may they be concerned about? Maybe a lack of independence, social isolation, fear of embarrassment if they have seizures, use of alcohol or drugs, social stigma that can come with having seizures, and then driving. Will they be able to drive? That may be a big concern for them. So with children with seizures, we really do want to try to normalize it. We want to only place essential restrictions on activities that potentially could cause injury to the child. So we really still want them to be able to live their best life and do the things that they want to do as long as their seizures are managed. But again, we want to make sure that they are safe. Really setting realistic limitations and helping them learn how to manage living with seizures. And then to end our discussion, I wanted to mention status epilepticus. And this is one of the most common cause of neurologic emergencies in children. So what this is a continuous seizure that lasts longer than 30 minutes, and the child can have no return of consciousness or even can result in death. While it is defined as a seizure lasting longer than 30 minutes, to really prevent it from getting to this status, patients are treated for impending status at 5 minutes of seizure activity. They are often treated for impending status at 5 minutes of seizure activity. So initial treatment is supporting the airway, so your ABCs or your CABs, administering oxygen and obtaining IV access, followed by IV administration of anti-epileptic medication. So then for inpatient or hospitalized children, IV diazepam or lorazepam are first line of treatment. Lorazepam or Ativan is typically the first line of choice because it has a rapid onset of 2 to 5 minutes and a long half-life of 12 to 24 hours. And then while you still can give rectal diazepam or Diastat in the hospital, this is often prescribed for at-home or non-hospital use to stop bouts of prolonged seizures or clusters of acute repetitive seizures. So this may take about 15 minutes to work. And another medication that may be used for in-home or pre-hospital treatment includes buccal midazolam, which takes about 8 minutes to work. Again, if patients do have a history of seizures and they're sent home with rectal Diastat, making sure their caregivers or their adults do know how to use it and when to use it. It's really important to note that with any of these medications, respiratory depression is a main side effect. Caregivers are instructed to call 911 if seizures continue 10 minutes after the medication is administered. They really should be evaluated after if they do require administration of these medications at home. And then one last thing is that any patient that has a history of seizures, that when they are in the hospital, really need to be placed on seizure precautions when they're admitted. And this includes side rails are raised when the child is sleeping or resting, and then they're padded, or any other hard objects that they may come into, making sure they're having suction at the bedside, oxygen at the bedside, that there's an alert. They may have a band that says that they're seizure precaution. I haven't seen that as much, but they may wear a bracelet outside of the hospital setting. So that ends this presentation, and I hope you have a wonderful day.